Check 1, 2, check, check.
Yeah, okay.
Everyone. And it's just going to look like this. So you just, since you don't have a PowerPoint.
Right.
Okay, so you can go ahead.
I can start? Okay. Good morning. We greet you on this day at this professional education event that's being presented by the Sickle Cell Services of the COBRA Agency, supported by the Medical University of South Carolina Sickle Cell Disease Services. We wanted to give you just a brief description of the COBRA Human Services Agency's work in the area of sickle cell disease. And we've been in existence, the sickle cell program, since 1972, so that's 50 years. Our relationship with Medical University of South Carolina started in 1969, when the president and some leadership of the Medical University Institute was working along with Mr. William Saunders, who was the founder of the COBRA Human Services Agency. And Mr. Saunders was one of the individuals that helped in negotiating on behalf of the African American nurses strike in 1969. And so from 1972 to 1982, the COBRA agency was one of 21 model programs in the nation to be federally funded. And of course, for those 10 years, which was before block grant came into existence, we got direct funding. And we were one of the models because we were the community agency that subcontracted with the South Carolina Department of Health and Environmental Control for testing. And then we subcontracted with the Medical University of South Carolina for sickle cell disease counseling. And that's where I started my work with the COBRA sickle cell program, being a counselor, and Dr. Wertelecki, who was a part of the pediatric department at Medical University, hired me in order to do the counseling, so that he didn't want to have to train somebody from the beginning. And of course, the funding that we received was really the only federal funding for sickle cell in the state of South Carolina. And actually, the Charleston County Comprehensive Health Planning Board and the Committee on Better Racial Assurance worked with 9 legislators to get a sickle cell program funded at DHEC, because we were funded federally to provide community-based sickle cell services, but there was no sickle cell program for the general community in the state. Funding was received through the state legislation of South Carolina in March of 1972. And so then from that point on, DHEC has had a sickle cell program. And now, after the block grant came into existence, the money that the COBRA was receiving to provide sickle cell services, that money went directly to DHEC. And the DHEC used those dollars that came to them because we were funded. They used those dollars to fund 3 sickle cell programs in the state of South Carolina. And of course, the Clark Foundation that's stationed in Columbia, as well as the Barksdale Foundation that's stationed in Spartanburg, and of course, the COBRA agency. Now, the COBRA agency was already working with the Orangeburg Area Sickle Cell Anemia Foundation, and because they were doing an excellent job in helping patients to be treated in South Carolina as well as in Georgia. But they were not doing the actual community education, testing, and counseling. We were federally funded to do that. So anytime they had a need of that kind, they would refer uh, those service needs to us. So we decided when DHEC was splitting the money, there was no money to give to the Orangeburg Foundation because they were not providing a good bit of community education as well as community testing. But what we decided to do, we would let them work with us. And we knew that several years later, there would be a state plan, which we were a part of helping um, to get established, the first state plan for sickle cell disease in the state. And we knew that if that's done, we would get a little more funding. So we decided to split the 15 counties that we were covering with Orangeburg. We gave them 5 of the 15, and of course, then the money that accompanied that. And of course, we kept the 10, and we are still serving 10 counties even today. Actually, in 1985, Sickle Cell Services of COBRA presented and received state legislative funding for a 2-year pilot newborn screening project in South Carolina. That would be from 1985 to 1987. And since Mr. Saunders had a relationship with Medical University, he was able to speak with Dr. Charles Darby, who was chair of the pediatric department at that time, to see if he could get Medical University to test every baby delivered at Medical University for those 2-year periods. And of course, Dr. Darby assigned Dr. Pye to be the person to manage the medical university aspect of the newborn screening. Now, Dr. Jackson had helped develop the first sickle cell clinic in the state. And of course, because so many of the other hematologists were not interested in that, but she was interested, and so she was able to treat those babies identified in the pilot project, as well as I guess babies from other hospitals as well, because Dr. Pye was able to get some SPRANS funding, special projects of regional and national significance. He was able to get some additional funding, and so that he could include some other hospitals in the testing in the Charleston area in the newborn screening pilot testing. And of course, Medical University also provided laboratory analysis in order to make sure that what DHEC was producing, that it was adequate. So then, actually, after the 2-year project was concluding, I suggested to Dr. Pye that he could use some of his funding that he got from the SPRANS project, and let's bring Dr. Ekman from Atlanta, who could actually help us convince DHEC of starting a statewide newborn screening program. So at the end of that 2-year project, beginning in July of 1987, there is now statewide newborn screening for sickle cell, and that was added to the battery of other tests that DHEC was already providing statewide. And we saw that it was easy just to add sickle disease to that. And of course, the babies identified as having trait were subcontracted with the community organizations so that those families would be tested, will be counseled and then tested as well if they care to. We actually were a part of really initiating some services here in our state. And so we wanted to share this information so you could see why the COBRA agency is involved in sickle cell services. And so we continue to do that. And of course, this professional education event is also another aspect of the services that we are providing so that other professionals and their support staff would be able to hopefully do a better job of teaching, of treating their patients. Now, today, we're going to continue the actual presentations. I'll be introducing Dr. Sharon Jackson, who's going to be our first presenter, and following that, she will at least indicate the other aspect of the services that will be provided on today. As a short bio to Dr. Sharon Jackson, she received her MD degree from Medical College of Georgia, and then completed training in pediatrics at the Medical University of South Carolina in Charleston. And then she joined the faculty here at MUSC in 1985. She's board certified in pediatrics, and she's a member of the Medical Honor Society and the Charleston County Medical Society. She completed an academic faculty development fellowship at University of North Carolina, Chapel Hill in 1990. As an associate professor of pediatrics at MUSC, she's director of the Pediatric Sickle Cell Clinic and provide care for more than 600 children. She is involved in clinical research at the state level and at the national level. Sickle cell patients participate in clinical trials for the development of the TCD screening for stroke prevention and the investigation of hydroxyurea for children. So she is involved in medical education and serve as the director of pediatric clerkship for third-year medical students. And she is participating in education research and curriculum development. And I want to add just a few more points. Dr. Jackson has really been an extremely beneficial asset to Medical University of South Carolina to help develop the sickle cell clinic at the pediatric level and many of the other services that have proceeded because of the fact that that program was in existence. Okay, she has really have done a lot in our area. In fact, with DHEC, she's served with some of the meetings, state meetings, giving professional input. She has also served on the as a resource person to the Sickle Cell Advisory Board of the COBRA in earlier years. And so we are very, very appreciative of all of her work. She really has actually contributed an extensive amount of organizational work in the area of sickle cell here at Medical University and beyond. And of course, we have she served hundreds of children, but also it's really difficult. We've not heard a patient or a parent make a complaint against Dr. Jackson because she's very interested in the total person. And they realize that, and she exemplifies that as well. And so the bone marrow transplant that has taken place here at Medical was because of the fact that there was a foundational clinic already in existence, and they could kind of go beyond that. A lot of the additional research that they've been involved in has been because of the fact that there's been this pediatric sickle cell clinic. And so we really appreciate her work and her legacy in sickle cell disease. And so now I present to you Dr. Sharon M. Jackson.
Clicker.
Thank you. Good morning. Thank you very much, Reverend Cook, for introducing me, and welcome to our sickle cell discussion today. I'm always excited to talk about sickle cell disease and share what I've learned in taking care of these precious patients. I have a few objectives. We just want to do a little review of sickle disease and also talk about models of transition, taking patients from pediatric care to adult medical care. And this is an important topic. It's why we're having this session today, bringing attention and awareness to such an important issue. First, what is sickle cell disease? Most of you know sickle cell is a blood disorder affecting the red blood cells. Those small cells are responsible for carrying oxygen to every part of the body. With sickle disease, there's been a mutation, a change in the genes controlling sickle cell hemoglobin, and this causes the cells to become crescent moon shaped or sickle shaped, instead of being round like a donut, and this interferes with the ability to deliver oxygen to the tissues. When this happens in every part of the body, in every organ, it creates a log jam of cells that interfere with oxygen delivery, and the patients experience pain that we know is the hallmark of sickle disease, especially in the bones and joints. This picture shows a very magnified description of the red blood cell. On the left, those are normal, healthy red cells. They look like a donut. But on the right, you can see the cell has been stressed. The sickle cell has been stressed, and it takes on this crescent moon shape. And this interferes with the ability to deliver oxygen to the tissues. It affects every part of the body, the sickling process, because blood vessels carry oxygen, red cells and oxygen to every part of the body. So if it happens in your brain, the patient can experience a stroke. When it happens in the lungs, we call it chest syndrome, acute chest syndrome. Sickling happens in the spleen, in the kidneys, at the bones and joints we've already mentioned. But any of these areas sustain damage over time, and this is why it's important to understand the transition of patients to adult medical care. Many of these complications are going to manifest when the patient becomes a young adult. Some additional facts about sickle disease. It affects, in America, it affects about 100,000 African Americans, but other patients of other ethnicities are affected as well. Patients from the Hispanic countries, from Africa, the Middle East, and India, and many of these patients are living in the United States. So there's the opportunity to take care of a variety of patient ethnicities in our practice. Sickle cell occurs in about 1 in 385 births, African American births, and there are about 3 million persons with sickle trait in our country. Interestingly, the treatment for sickle disease, these are medications that prevent the sickling process. We only have 4 medicines that are working to prevent a sickle crisis from happening. Hydroxyurea, you've heard us mention, we started using it about 30 years ago. And then for a long time, we had no other treatment options. In the last 3 years, we've had 3 new medicines. Endari or glutamine is one, crizanlizumab is another, and voxelotor, the third one. So there's been a flurry of use of these new medications, especially in adult patients, in the last few years. Remember, bone marrow transplant is actually a cure for sickle disease, and gene therapy is even newer as far as cures are concerned. But those new interventions have limitations. We don't have the ability to do transplants in every patient, and we're still learning and getting our experience with gene therapy. Transfusions have been a lifesaver for our patients over the years. We've used them to treat many of the complications of sickle cell disease. Now, babies are diagnosed at birth. Reverend Cook mentioned for us the newborn screening program. And unfortunately, in the early 80s, South Carolina was one of the last states to start screening. That's part of the reason I ended up remaining here for my training and staying on to help get sickle cell newborn screening established and the clinic established. We lost babies in infancy from sepsis, and it was heartbreaking to see these are babies that we didn't know had sickle disease. They were dying from the complications of infection. So we've had newborn screening now since 1987, statewide screening, and that has led to the survival of these children outside of infancy and toddlerhood into their teenage years and adult years. So reasons for reasons for survival are newborn screening, and starting penicillin prophylaxis as soon as those babies are diagnosed, at least by 1 month of age. We use bacterial vaccines. That has made a tremendous difference. Babies are surviving because they're vaccinated, and we manage fevers aggressively. Every baby, every child, every adult with fever 101 or higher needs a sepsis workup and antibiotics. And this has led to the survival rates that we're reporting here. The improved childhood survival in the Dallas cohort starting 2000, year 2000, and a second cohort started in 1983 up to 1990, and we've gone to up to 2007. 99% of patients with children with sickle disease are surviving, according to the Dallas cohort. The London studies and Jamaican studies, not quite as high survival rates, but in America, we have the opportunity to provide resources for caring for patients and adults and children with sickle disease. We're blessed to have that advantage that we're able to provide care for our patients. Other countries, of course, have a difficult time with resources, but we have been able to concentrate and emphasize the importance of diagnosing sickle disease and treating babies and children aggressively. The typical model for pediatrics is that, as in any other childhood practice, the parents are mainly in charge of the children, and that's what we see on this picture, the parents and the young child. And that model exists until about 18 years of age. Most times, pediatric patients are transferred or moved on to an adult provider when they turn 18. The issue is, it's not that we don't want patients to leave us. We just want to make sure that they're ready to go, that they're prepared to take on their healthcare issues and function like an adult. So we use the term transition, and transition means a process for transferring the medical care from pediatrics to an adult provider. This slide reminds us that I just celebrated the survival of children into 18 years and older. But guess what happens into their early 20s? A very high incidence of illness and medical complications in the 18 to 30-year-old group of patients. This slide shows us patients who had annual encounters in the emergency room and acute care. That's the highest point in patients' lives, that 18 to 30-year-old group. This is when the adult medical care is so important and so critical. Part of the reason patients have more complications, they just fall out of the system. When they finish with pediatrics, they don't get established with an adult provider, and they just hop from the ER periodically, but there's no organized care process for many of the patients. I do want to mention a few other issues referring to access to care. It's discerning that about 75% of patients, adult patients with sickle disease, are not on hydroxyurea for some reason. And remember, we said the first medication available to help us manage the sickling complications. But for a variety of reasons, patients are not on it. This is what we have to work on as part of a transition medical care plan, is to ensure patients have access to the options, medication options that we mentioned. Another discerning fact, the majority of children with sickle disease are not getting the TCD screening. That means transcranial Doppler ultrasound will help us identify children at risk for stroke. And stroke is a major complication in children and adults. And we're able to, with the research that we've been part of, We do these Doppler screenings starting at age 2 years and identify ones who are at risk to have the stroke, start them on blood transfusions, and we've had tremendous success with this intervention. Again, barriers to children getting the TCD. There's studies going on right now to help us figure out why are so many children unable to get this very easy, non-invasive procedure that can save their lives. So this is an area to keep working on in pediatrics. And then 73% of family physicians believe that they need more education and more support to take care of adults with sickle cell disease. And we'll talk in a minute about one of the barriers to a successful program for transition. We don't have enough providers. This slide is from Dr. Sarah Manito. She's a MedPeds hospitalist physician here at MUSC. And a few years back, she studied sickle cell patients in a rural area not far from Charleston, and tried to find out how patients felt about their transitioning to adult programs, adult providers. And you'll see the tallest column is 100% of patients. These are young adults, like over 20 years old. Their biggest anxiety or concern was leaving the pediatric practice. 100% of patients were heartbroken to leave. Of the adolescent patients, these are the signals in blue, about 60% of children were adolescents were kind of anxious about leaving and moving to a new provider. But I think the reason the young adults were more upset is because they had been, as typical, most practices, they will have been in that practice for 18 years, 20 years. Since they were born, they've become accustomed to the team, the medical team, the policies and practices in that clinic. And so it's a big deal to say, you're not going to be with us any longer. You're going to start over with somebody new. So that was the overwhelming impression from this study that was done a few years ago in South Carolina. Now, there's in terms of transition structure, there's been lots of research since 2000, and the research has shown us there are 6 core elements to healthcare transition. And I will say that most medical practices, pediatric practices in the United States, use this framework in either totally or parts of it in order to implement a transition program in their practices. So the areas we're talking about are transition policy, tracking, monitoring, readiness, planning, transfer of care, and completion of care. And we'll say a word about each of those categories. The first is policy. And in policy, we're talking about the statement of the clinic's behavior. What are we going to do about transitioning our patients? How are we going to do it? At what age are we transferring patients? And we have to get the patient ready for that transition process. And this policy statement tells you how to do that. The policies are usually published or documented where patients and families and the medical team has access to it. The second is tracking and monitoring. So this is where we document the criteria for transition. We track progress in a registry. Not many of our programs have registries, and this is something to work on. A national registry would be wonderful. And we've seen models with other diseases like cystic fibrosis, where there's a national registry for tracking patients with this disease, with sickle disease. We use the electronic medical record to help us keep up with the steps of the process. And it's, the medical conditions and complications are such a big part of the sickle cell patient's course. Then we have transition readiness, and this means we use questionnaires or assessments for both the patients and the parents to evaluate how much the patient knows about the sickle disease, their sickle disease, and how do they feel about it? Are they anxious? Are they worried? Do they have questions? The surveys are repeated at scheduled intervals, and the responses to those surveys help us set up goals for each individual patient. The next, these are examples of questions on the assessments. Most of them are one page, 20 questions. They ask about the knowledge, the patient's knowledge and parents' knowledge. They ask about your medical history, how do you manage your pain, psychosocial issues and academic issues are covered. And again, the majority of programs in the United States use this model of core elements to support their transition programs. The next part is called planning, and this is when we update the medical care plans, emergency plans. We talk about our patients becoming legal adults at age 18. We talk about when they're going to be transferred and identify an adult provider, talk about insurance and other resources. The transfer of care, that's the actual movement of the patient to an adult clinic. And this is when we confirm they've had their first appointment. We prepare a transition package that has medical summaries, their assessments, their plan of care, emergency plans, and we communicate with the adult provider. And then completion is when the patient actually makes it to the adult clinic. We have to confirm that the patient made it to the clinic. We should get feedback on how that experience, how they dealt with the experience. And we continue to collaborate with the adult providers. That's a very big part of supporting the patient after they leave the pediatric group. And it allows them to build trust in the new providers, the new attendings, and medical team that they're going to be working with. At MUSC, we have a transition program that's based on this model that we just discussed. We have a transition coordinator, Rachel. She's not able to be with us today, but she's responsible for organizing and monitoring and documenting the evaluation of our transition patients. We have a sickle cell social worker. We'll meet her in just a minute, Mrs. Ife, and she assists the coordinator with monitoring and following these patients on the pediatric side and on the adult clinic side. There are key encounters for assessment starting at age 15, where we evaluate medical knowledge, the medical care plan, the prescription details. The patients will learn how to order their own prescription refills. And we have a voice crisis app on their phones. They can document when they're having a pain episode and share that information when they come in for their visit. At age 16, we talk more about the patient learning how to schedule an appointment, how to arrange their own transportation, if they're driving or learning to drive, how to incorporate that skill into their independence and getting themselves to their appointment. And we talk about how to fill out medical forms that they're going to be faced with in the future. Age 17 to 19, we set goals for life after graduation from high school, talk about work opportunities, going to college, taking SAT and ACT exams, talk about insurance plans, and discuss permission for parents to have access to your medical record, which has to be a written permission. At age 24, we introduce the adult sickle cell providers and provide a handout explaining the adult policies. And we spend some time discussing the differences between the two clinics. Peds clinic is different from adult clinic. Age 25, we schedule the appointment with the adult clinic, contact the patient to see that they attended, and get feedback on the experience from the actual patients. And I didn't put a slide in, but the coordinator mentioned to me that she's been interested to see that the ages of patients make a difference. The young patients, 15, 16-year-olds, are completely lost when she first starts with them. And they show the greatest improvement in learning as far as education about their medical condition. And they're not afraid to move to the adult practice yet, just as we saw in that graph. They're not too worried about moving because it's a few years away. And look at this age spread. Our clinic, pediatric clinic, keeps the patients until age 25. That's much longer than most practices, but we found it was helpful to hold on to the patients because the adult practice was overwhelmed with patients and needed additional providers. And so this has allowed us to continue to give quality care to the pediatric young adults in our practice. But the older patients, 24, 25-year-olds, have already learned how to manage themselves as adults. And so we feel confident that they're ready to move over to the adult practice because they've had 3 or 4 years to practice being responsible, taking care of their own responsibilities related to their health and their management at MUSC. Now, I just wanted to mention a few other transition programs. These are from hospitals around the country. And as I said, most are already using the core elements. So I just took 1 or 2 points to share with you that makes these programs unique. So the first one is the Johns Hopkins program. It's called SCULPT. You'll notice we use a lot of mnemonics and initials to represent sickle cell programs. And this one is unique because they have a special peer and parental support group just for the transitioning patients. They do everything else that we just described as far as educating and going over your skill set, but the peer support is a special component for their practice. The St. Jude program has been one of the models for scholarly research in terms of describing their transition program. But in addition to the scholarly model, they have a STEP program that's called Sickle Cell e-learning, and this e-learning project, and this involves interactive modules where they quiz the patient about sickle cell disease. There's 6 modules altogether, and the patient can go online and just click on the questions and answers, bring their quiz results to their nurse practitioner, their clinic coordinator, and they get incentives. They get, rewarded for being involved in the learning process about sickle cell disease and transition. The third one is the Children's National Medical Center in Washington, D.C. And I thought it was interesting that they have a self-advocacy program within transition where they have it's called Strive, and they have meetings with mentors and other community agencies to help introduce advocacy. That means the patient can speak up for himself, advocate for his needs, make it clear that he knows what he needs as a young adult patient. And so that's a portion of what we want in all our practices, all our programs, but theirs is a nice model, and I thought it was interesting that they have included it. The CDC gives transition education, and they're special because they have a series of personalized patient videos. Oops, we lost the O on video. But patient videos, I've watched a few of them. They're very, very well done, and they give you a sense of what it's like to be a patient with sickle cell disease. Medical College of Wisconsin has a program called EASE, EASE, stands for Empowering and Access for Sickle Cell patients entering into the adult world. And I thought it was interesting. They have a table, a chart that compares the parents' responsibilities on one side, and it lists the patient's responsibilities on the other side. And then you can see the turnover, the crossover as the patients are getting older, the duties that parents had now become the duties of the patient. And sometimes I think it takes patients seeing it visually and hearing us say, you're now going to be responsible for calling for your appointment, calling for your medication refills, for telling the doctor at the ER what your pain is, what your symptoms are, whereas children are used to the parents speaking for them and acting on their behalf. But this chart shows it in detail and it's a list of maybe 15 responsibilities, that those crossover responsibilities become apparent, and they can visualize the responsibilities when you see them on the chart. The next one is Rethink Sickle Cell Disease, and this is another online a resource for videos, all kinds of education that our patients are welcome to be using. Rainbow Babies and Children's Hospital, the patients are given a comprehensive transition handbook, and they can enter their information into the book so that they keep it with them at all times, and until they get to the adult clinic, adult practice, they can have at their fingertips have a complete report of what they're going through. And then finally, there are 2 transition studies. There are many, but here are 2 transition studies that are randomized trials. So they are going to help provide evidence for the best way to provide transition interventions. And they're funded by the Patient-Centered Outcomes Research Institute. The first one is called Step Up, and it stands for, it took me a while to figure it out, but the S is for sickle cell, but T is for 3 T's, and named after Trevor Thompson transition. So it looks like a backwards E is why when you see Step Up. But this study involves 700 patients in the United States at 14 hospitals, and it evaluates education with a peer support versus standard education. So this is helping us learn what is the best way to educate our patients before they move over to the adult clinic. And the second one is called COMETS. It's a community-based intervention. So community health workers are responsible for the education, and they are compared to the patients in the second group have the iManage app. So that's a self-learning kind of tool. And then the third one is, quote, usual care, which is where your clinic physicians and providers do the education in some form or format. So successful transition outcomes, we have learned since 2000, we've been doing small studies, and we found that a successful program has a spirited adult healthcare team. You have to have doctors and teams who are wanting to take care of adults with sickle disease. And many are limited. Remember that family medicine statistic said 73% didn't have the skills, didn't feel comfortable. We don't have enough hematologists. We don't have enough tertiary centers like MUSC to take care of all the patients. We have to rely on primary doctors, general practitioners, family practitioners, community doctors to see the need and agree to take on these sickle cell adults. And again, like Reverend Cook mentioned, in South Carolina, we just have 3 comprehensive centers, Charleston, Columbia, and Greenville. And all the other patients in the state have to come to one of those centers for care. We still have to rely on the primary doctors in your community to work with us at the tertiary centers to be able to provide, as we've been doing, pediatric care, but we want to continue that model for adult patients. The other successful marker is whether the patient actually went to the appointment. And what happened in the early 2000s, patients didn't go. They were referred and they felt like they were abandoned and they didn't know these people. They didn't know where to go. They didn't know how to get in touch and say, you know, help me, I need help. And they just dropped out of the system. They didn't have any comprehensive care after that. So attending the appointments consistently is another evidence of success. And this is what our coordinator and social worker help us monitor, is that the patients are actually going to the appointments. You know, we use emails and text messages and MyChart and every method that we have to try to keep up with the patients once they've been transferred. And then the patient can demonstrate improved knowledge. That's evidence of success. Whatever method you used to get those patients ready for transfer, if they have knowledge, increased knowledge about the disease, their disease, then that's considered success. Barriers to success, we mentioned already, limited adult providers. Patients have had traumatic experiences in the adult ER where they're not believed, they're not respected, they're being stereotyped as having dependency, drug addiction and dependency. And all it takes is one experience that's bad, and that patient will not go back. They can be hurting and need medical care, and they'll say, well, I'm not, this is different from the way I was treated in pediatrics, and I don't want to go through this. I'll just stay home and take my pain meds and do the best that I can. The third concern or barrier is inadequate knowledge about sickle disease, very complicated. And recall the organ complications escalate with age. So the older you get, the more sickling damage you'll have, and you'll need more medical care. This is why it's so important for you to be into an adult program and not just be told, go to that appointment, and then nobody else follow up on it and follow up with you to make sure that this is happening. Difficulty navigating the healthcare system. Even me as a doctor, I have trouble in the healthcare system knowing where to go, who to call, what to do. It can be overwhelming. And again, we need the support from the patient, from the pediatric clinic and the adult system to give an umbrella to cover the patients, especially during the transition years. That's all of the information that I had. I did want to end with this slide of these beautiful school children having fun at the beach. And these represent the patients of tomorrow. We're working now with the transition models to have a program ready and robust when they get to be young adults, that they will have a process to go through that prepares them to be adult patients in a supportive adult practice. Thank you very much. Okay. How did I do, y'all? Was that good?
That was good.
Okay, good.
Saw it on the screen.
Yeah, see how come your notes?
Oh, your notes are gone.
Let me see.
There they are.
It won't show it. Well,
But I can read it from here.
but Will show on the screen too. Cleaner if you do it on. Odessa, would it be okay if she ran her PowerPoint where it shows the notes at the bottom, or it would be better to have it full screen?
We normally just see it on the computer that we're looking at, but you're saying it'll show
It'll
what
everybody.
everybody's
Yeah.
watching.
I mean, she could show it where there's like all, they would see the slides on the
The
side.
notes.
And the notes.
But you said you could use this
It would
computer?
reduce the quality a lot.
Okay, well, but that's something that,
Yeah,
You
can
can
just
use
set
it
up here
if you
and
can
just go
read.
between.
But then you'd have to still advance both computers.
Yeah.
Change the size of that. I think it will save that. So then you go to the next one. See that
You
one
don't-
has the notes.
You don't have them
So-
on every one,
No, I don't.
Yeah,
so you'll use this one.
you just have to click over here on the side. Click up and down.
Okay.
There's your notes.
Okay, let's go back to my introduction. All right,
I'll sit here on the side.
okay. There we go. Can we start? Good morning. I'm pleased to introduce Mrs. Ife N. Cromwell Milton. She will be our next speaker. Mrs. Milton is a licensed medical social worker at Medical University of South Carolina. She works with sickle cell patients who are admitted and those in the ambulatory clinic, the adult clinic, and pediatric clinic, and she works with their families to provide a continuum of care. She's originally from Brooklyn, New York. However, she grew up in Charleston, James Island, and is a United States Army veteran. Thank you for your service. And she earned her master's degree in social work from the University of Southern California. Ipe believes in meeting people where they are so that they can achieve the best outcome for the results they want to achieve in their lives. Let's welcome Mrs. Cromwell Milton.
Thank you, Dr. Jackson. Good morning, everyone. I would like to thank Dr. Jackson and Reverend Cook for inviting me. This is my first time presenting with COBRA, and I am new to sickle cell. So I have been learning a lot about sickle cell, and I've been blessed to be able to work with sickle cell patients.
Camera was getting off.
Was off.
I guess just restart.
Start over. Thank you, Dr. Jackson, and thank you, Reverend Cook. This is my first time presenting with COBRA, so I would like to say thank you for inviting me. I am new to working with sickle cell patients, so I would like to say thank you all for having me to work with you guys. And I've been learning a lot as I've been working with everyone, and I've been learning a lot from the families as well as the patients. And so I'm going to discuss transitioning with sickle cell disease. There's a paradigm shift. Transitioning occurs during all stages of life with young adult patients with sickle cell disease and their caregivers. it is important that everyone is aware of the shifts that take place, not only physically, but also medically. In the 1970s, sickle cell disease was considered a pediatric issue only. According to researchers, more than 90% of individuals with sickle cell disease live to be at least 21, which changes sickle cell disease from a pediatric only concern. Thanks to early management, 95% of sickle cell disease patients reach adulthood and require transition from pediatric to adult care. When thinking about the transition from pediatric to adult care, topics to be addressed are the young adult taking charge of their own health care, the guardian no longer having all rights to the young adult patient's medical and financial affairs, which I have been finding that the adults or the caregivers have been having problems with that transition, because as a parent, you've been taking care of this child all their life. You may have stopped working, you may have stopped going to school, you may have had to put your other children on the back burner somewhat so that you can take care of this child. And now that they're 18, the healthcare world is saying they're an adult. We're going to talk to them and not you anymore. And that's difficult for a parent. I'm a parent and I still am a little overbearing. So when you go into the room, you have to make sure that you're letting these patients and their parents know this is what's going on. However, there are documents that they can sign, and we'll talk a little bit about that later. Adjustment to a new care provider as an adult is one of the transitional concerns. Education and career goals, options while having sickle cell disease, and caring for themselves and psychosocial needs are all transitional concerns. For successful transitions, a healthy collaboration between the young adult, healthcare providers, and guardians must occur. Positive disease management and independence is essential for healthy outcomes. This is achieved by ensuring the young adult understands sickle cell disease, medications, how and when to achieve healthcare assistance, understanding insurance and disability benefits. At this time, it's time for the parents or the guardian to pass the baton. It's time for them to let go of some of the responsibilities they've had all 18 years, or in MUSC's case, 24 years, and pass it on over to the child or the young adult, the youth. It is imperative for the guardian, patient, and healthcare providers to have a discussion with realistic expectations of who will be decision-making moving forward with the transition. The caregiver should be made aware that conversations, billing, and documentation will be the responsibility of the transition patient. And this is where the difficulty comes in. Providers and caregivers will need to discuss the maturity and cognitive levels of patients so that documentation and transition into the adult world will not be problematic. Patients' insurance and disability documentation process, if applicable, will also need to be addressed and completed prior to the transition. Documentation giving permission for healthcare team members to discuss the healthcare of the patient is essential in building the young adult trust and avoiding HIPAA violations. No one wants to have HIPAA violations when discussing the patient's medical information with their parent. Some children, when they turn 18, they are like, this is my business. I don't need my parent in my business. Where there are some children, or young adults, I should say, that are like, oh no, talk to her, talk to my mom. They're not ready to release. And parents don't understand that it's no longer your responsibility to take on this role because they're 18. So it's a balance. And as a social worker, I have to go in and speak with them, or as our patient care coordinator, we have to go in and speak with them and say, hey, we have a form. And most places have a form that they can sign, and they can release that, ability for us to speak with their parent or whoever the legal guardian is. In some cases, the documentation for the child, it's essential to understand if there is a cognitive delay, because then we have to go another route. You can't always say, oh, because the child is 18, we're going to let them make all the decisions. Well, if there's a deficit and the child is not able to sign everything themselves, we have to take that into consideration also. Understanding the body. So not all patients understand their body completely because the parent has been taking on all of this responsibility and letting the child just move on their lives as a happy child as best as possible. And they were not learning anything about the sickle cell disease, but the parent was taking on the role of learning everything. Patients need adequate knowledge of the sickle cell disease, i.e. reproduction and genetic inheritance. So what's important is that the youth should begin with the guardian and or healthcare team to discuss reproduction, because whomever they choose to procreate with may have the trait or the disease. So they have to understand when procreating, because we all know these children are going to grow up. They may want to have a family. They have to understand when you go to procreate what the chances are of you having a child with sickle cell disease. Also, for male patients, they have to understand the effects of sickle cell disease on testosterone levels and sperm. Menses onset is delayed in females with sickle cell disease, and menstrual bleeding patterns are normal. However, sickle cell disease is in association with an increased sickle cell disease-related pain. So at 13 or a little before 13, we start discussing with young females that sometimes their crisis may come on because of menstrual cycles. That's important for them to understand and know what some of their triggers are. It is also necessary for the youth to have adequate knowledge of baseline hemoglobin levels, as well as understand when to seek medical attention. And not be shy to seek medical attention. Some children keep pushing because they think they can handle everything. By the time the youth are ready to transition, they should recognize pain triggers. The youth need to have the ability to name their pediatric and adult hematologists, also know how to contact them. Some of the factors that cause sickle cell disease are infections, low oxygen tension, dehydration, physical, psychological stress, alcohol, pregnancy, and cold weather, just to name a few. It is also imperative in transition for youth to be responsible for knowing their pain regimen and the medication that they take by name, dose, and the effect reactions that the medication has on their body. Patients' ability to self-manage is important in the transitioning process for best healthcare outcomes. Some of the medications that they may take could be opioids, corticosteroids, acetaminophen, and NSAIDs. Patients must be able to recognize which medications may cause drowsiness if they come into acute clinic, if they can drive home, which in most cases they cannot. They have to be able to identify someone who can drive for them prior to even coming to clinic. And if they can't have anyone drive for them, maybe they can use Medicaid as a transportation. And if they are planning on doing that, they have to know how to use those services. So they have to be taught how to use those services, not only for the parent, but also for the child, because maybe they want to use those services to come to their regular appointments. According to an article written by Health Day, News for Healthier Living, sickle cell disease attributes costs were estimated at 1.6 to 1.7 million for males and females, with an out-of-pocket cost estimating from $42,395 to $45,091. The study in Blood Advances takes note that sickle cell disease is expensive to young adults, especially if they don't have insurance. It is important for the transitioning youth to ensure they possess insurance coverage for medical expenses, because sometimes when they transition, they let their insurance lapse because they no longer want to be under their parents' care because they're grown, and therefore we have to make sure that they understand the importance of keeping healthcare coverage, because sickle cell disease or any kind of health problems is very expensive, and going to the ED is very expensive. Lab work is very expensive. Medication is very expensive. It's important for the transition youth to ensure they possess insurance coverage for medical expenses. Researchers also found that survival-adjusted sickle cell disease costs peaked at age 13 to 24 years and decreased at older ages. That's because it takes a period of time for them to understand It's important to keep my health insurance. It's important for me to go to my regular doctor's appointments. It's important for me not to go to the emergency room, you know, for my regular visits when I can have a healthcare provider. Once they learn that, and that's why it's important to have a transitional program, they can stay on track and decrease some of this bill that they will create for themselves. The Center for Medicare and Medicaid Services reports that among 11,790 Medicare fee-for-service beneficiaries identified in 2016, the national sickle cell disease prevalence rate per 100 beneficiaries was 0.20. According to statistics of patients ranging between the ages of 18 to 45, 98.3% have outpatient visits, 75.5% emergency department, and 59.3% inpatient stays. More than 70% of Medicare fee-for-service beneficiaries are dual eligible for Medicare and Medicaid. 4 out of 5 are less than 65 years of age and qualify for the benefits because they are eligible for disability insurance. The September 2020 report for the Centers for Medicare and Medicaid Services reports that there are 41,000, A sickle cell disease diagnosis is not always a rating for the Social Security Administration as a disability. It is important for guardians and the youth to understand that the benefit may end at the age of 18. The youth and guardians should receive documentation from the Social Security Administration to reapply for the benefit by their 18th birthday. So it's important to make sure you're looking out for the mail, because I've had patients that say nothing came in the mail and then their disability benefit ends, and then we have to go back and reapply. If the family believes sickle cell disease is disabling, they may reapply. If reapplying does not occur, benefits that are monetary and insurance, Medicaid, may end. This can cause a disruption to the family's household income, as well as treatment for the transitioning youth, interfering with healthy outcomes. This is an additional stress not only to the patient, but also to the family. Many families depend on the disability check because they have had to stop working to take care of their child or children in some cases. If the benefit ends, there's a possibility of the family becoming impoverished, as well as medical bills being acquired that the family cannot afford. As we see from the statistics, it is very expensive. Medical care is very expensive on its own. Most youth are used to guardians monitoring healthcare needs, setting appointments, handling insurance, receiving disability checks, corresponding with healthcare team members. Transitioning into adulthood changes the way that youth and guardians will have to think and function. There has to be a change, and change will come because you can't stop aging. Goals will have to be set. As pediatric patients, sickle cell disease may limit educational opportunities as well as career goals that patients may have hoped for. What I've seen is some of our patients have been sick so much that they've missed so much school, so many hours of high school or college. They may have set goals that they feel that they couldn't achieve. It's the responsibility of parents, healthcare team members, and whoever their family is to support them in this so they can keep moving forward, because these goals will keep them moving forward in their life and not just staying stagnant where they are. Care teams and family members can assist patients with educational goals such as support of completion of high school, enrollment into training programs, post-high school graduation, and assistance with career exploration. And I have even helped with resume writing. Whatever it is that I can do as a social worker, I am here. I am able to assist in whatever way possible. Other goals patients may have may be learning to drive or use public transportation. If it takes sitting down with patients and showing them how their local transportation company uses their bus system, if it takes putting out different driver school in the areas, these young adults, they are ready to be independent. The parents have to let them transition on. The same way if they were going off to college if they were going off to the military, these patients are going to transition on, and we are going to be able to assist them in this process. It's a change, it's a shift. The goal should be all person-centered because all patients are different. Everyone has different goals. Whatever this patient's goal may be, may not be the next person's goal. Person-centered with guardians and healthcare team members supporting the specific, measurable, attainable, and realistic time-based goals. Not accomplishing goals can cause psychosocial distress. Everyone knows when you have a goal and you don't accomplish it, you get a little antsy, you get a little anxious. And sometimes that anxiety and that anxiousness can cause a little depression, which then can take you into stress, which then can take you into a crisis. And we want to avoid that at all costs. Psychosocial needs. Complications of sickle cell disease can cause challenges in various facets of life when a patient transitions into adulthood. Some issues are anxiety, body development, and low self-esteem. These issues can cause problems with medical regimens. Transitioning patients may become anxious about how the adult hematology team will accept them and their complaints regarding pain, financial, and treatment responsibilities, like we said before. When they're transitioning and maybe the insurance is not there anymore, so then they can't go to their doctor's appointments, and then they have to go to the ED because they have to be seen because they're not feeling well. Those things all cause anxiety. Or maybe they're afraid of what the new physician will say when they move over to the adult team. So just a warm welcome by the adult team or the adult nurses would be helpful for these patients so they can understand that the pediatric team and the adult team are working together. And being that I work with the pediatric team and the adult team, I can be there and say, hey, I'm here. You need me, just give me a call. When they come to their first appointment, I can be available, just to say, hey, you have someone here that you knew from there. Now you know someone here. And it's just like an equal balance between the two. Sickle cell patients typically feel that they are considered as drug-seeking medication when they go to the ED. That can present as problematic for them because when they go to the adult ED, like Dr. Jackson said earlier, they may never want to go back to the adult side. And I've had patients say they don't feel comfortable, they're angry, they're upset. So we have to ensure that the emergency room understands how these pediatric patients are transitioning. I have met patients in the emergency room. If I see that they're down there, I'll go down there and talk to them. I'll talk to the nurses down there because it just makes the transition a little easier for them. It makes things smoother and makes them feel more comfortable in knowing that they're transitioning from pediatric to adult care. A young adult typically does not feel comfortable using the adult emergency room or seeing the doctor to make complaints about pain because they don't want to be considered as drug seeking. Some of the patients understand that if the insurance has lapsed, the bill for emergency care or their inpatient visit may not be possible. That is why it's so important to handle all of these things prior to this transition over. Make sure that whoever the guardian previously understands that this is where we're moving towards. Make sure the child understands or the youth understands this is what we're moving towards so that everything is handled before they even get over to the adult world. So there's no hiccups in between. During the adolescent years, puberty occurs. That's a natural progress of life. In patients with sickle cell disease diagnosis, normal physical development is delayed sometimes. Patients may be smaller in stature, have a delayed or abnormal sexual development, and experience feeling of being different. And I have noticed that with some of my patients. And as they get older, some of them grow. That's a natural progression of life, the same as with other children, same as with regular puberty. As discussed previously, females begin menarche later than other female youths. Males may experience priapism, and both male and females may have significant lower weights and heights in comparison to youth with sickle cell disease. Along with physical development challenges, the youth may have a port, which may cause difficulties in them feeling comfortable wearing certain clothing and participate in certain activities because they are self-conscious of their appearance. This is something that we all have to take into consideration, and we have to think about this when we're working with these transitioning youth. We have to think about it when we're thinking about what they're experiencing and when we're addressing them. And the guardian also has to think about this as well. So again, we're passing the baton. As you see here, you see your dad, he's passing it on. He's moving on, and the daughter is taking it and she's running with it. Young people with sickle cell disease are living longer than previous years and have many adjustments to make. Parents and youth alike will need to pass and receive the baton, allowing the youth to pick up personal responsibilities just as parents do when children leave the home. Planning for the transitioning and starting with discussion with the family around the ages of 13 to 18 ensures that not only is the youth ready, but so are the guardians and the healthcare providers. This concludes my discussion on transitioning. I thank you all for listening. Remember, everyone, that June the 19th is World Sickle Cell Day, and I hope I presented you with something to take back and teach others, and I hope you were able to learn something today. Thank you.
Thank you, Ms. Ife. That was wonderful. We learn a lot every time we have presenters, and we appreciate the opportunity for you to be with us today. At this time, we're going to take a short break. When we come back, we'll be having a discussion with a patient living with sickle disease, Mr. Buford, and we'll have a chance to explore some of your experiences and share that with our audience. Thank you.